On-the-scene coverage of ACC 14 is supported by Janssen Pharmaceuticals Incorporated.
I'm Peter Block for On the Scene here at ACC at its annual meeting in Washington, D.C. So I've got a question for you. For a patient that has atrial fibrillation, or if you have a device that spots atrial fibrillation, should you start anticoagulation? Should you stop it when the rhythm goes away? What should you do about such patients? And with me is John Halpern, who's from Mount Sinai, New York. John, you've just done a study which answers some of these questions.
We have. It's the IMPACT trial of patients who had implanted cardiac devices that could broadcast through wireless telemetry the atrial electrogram. We knew when they had atrial fibrillation. We knew when it was not present. We anticoagulated in the intervention group based on the presence or absence of atrial fibrillation and the patient's risk of stroke. The control group was managed conventionally without knowing that information.
Okay, so if they had a device, what should I say, suspected or device detected arrhythmia, how did it work if the arrhythmia suddenly disappeared? How did those patients work?
Right, we would stop the anticoagulant for lower risk patients if they were free of atrial fibrillation for a limited period of time. Patients that had a prior stroke or a transient ischemic attack or systemic embolism, once we found atrial fibrillation, we would not stop anticoagulation. It started and continued.
Okay, so you made rules for the clinical management of these
right.
folks. All right, having said all that, tell me what you found.
Well, the trial was stopped because it turned out to be futile. There was no difference and no likelihood of showing a difference in the outcomes. And the primary outcome here is all thromboembolism, stroke and systemic embolism, and major bleeding. The idea, of course, is to stop the bleeding by stopping the anticoagulant, and we found that it could not be done in this study. And the futility was probably based on two things. Some difficulties with actually implementing the protocol as well as we had wanted. It's not that easy to get these things done. But more importantly, I think there was no temporal relationship between when patients had atrial fibrillation and when they were at risk of stroke. Of those patients who had both stroke and atrial fibrillation, there was no time connection at all. Many patients had their stroke before they even developed atrial fibrillation.
Okay, so this is a trial that ended in futility, and yet you're very passionate about this trial. We learned a lot. So give me the take-home message from this futility trial, which in fact taught us a lot.
I think it taught us that once we find atrial fibrillation in a patient with risk factors for stroke, we should begin anticoagulant therapy, and we should not stop it even though the rhythm seems to go away. This has important implications for strategies of rhythm control, does not mean stroke control.
Perfect. So anticoagulation, anticoagulation, anticoagulation.
When the patient has AFib, that's the answer.
If the patient has AFib, go for it. Thank you very much, John.
Thank you very much.